Welcome to Lesson 1, Schizophrenia, the classification of schizophrenia. My name is Nick Redshaw and I have over 16 years experience of teaching A-level psychology. I'm also co-author of the highly successful Student Learner series of workbooks, available exclusively on Amazon. So the classification of schizophrenia. The learning objectives of this unit is 1. The classification of schizophrenia, 2. Positive symptoms of schizophrenia, including hallucinations and delusions, 3. Negative symptoms of schizophrenia, including speech poverty and evaluation, 4. Reliability and validity in the diagnosis and classification of schizophrenia, including reference to comorbidity, symptom overlap, gender bias and cultural bias. The term schizophrenia means split mind. It comes from the Greek schizo, meaning split, and phrene, meaning mind. The term was first used in 1911 by Swiss psychiatrist Eugene Bleuer to categorize patients whose thought processes and emotional responses seemed disconnected. The symptoms of schizophrenia are complex and are often confused with other mental health conditions. This unit will look at the clinical characteristics and the issues that surround the diagnosis of schizophrenia. The classification of schizophrenia. Schizophrenia is a serious mental illness which affects the way a person thinks, and the symptoms may almost certainly have an effect on their ability to cope with day-to-day life. It is a common illness that affects around 1 in every 100 over the course of their life, and is equally likely to affect men and women. Schizophrenia is rare before the age of 15, but can start at any time after this, most often between the ages of 15 to 35. So a little exercise just to get you thinking. There are many myths surrounding schizophrenia. Write down what you think some of the common myths might be about people who suffer from this mental illness. Be prepared to share these if you're in class or on a board. You may want to pause the video at this point. Okay, welcome back. So, common myths include mental health problems don't affect me. Well, they do. Children don't experience mental health problems. Well, I know I said 15, but they do. People with mental health problems are violent and unpredictable. Not necessarily. Personality weakness or character flaws cause mental health problems. People with mental health problems can snap out of it if they try hard enough. Not that easy. Next myth, there is no hope for people with mental health problems. Once a friend or family member develops mental health problems, he or she will never recover. Not true. I can't do anything for a person with a mental health problem. Not true. Prevention doesn't work. It's impossible to prevent mental illness. Not true. The source of that was from the mentalhealthcare.gov, basic myths and facts, if you want to explore that further. So, moving on. There are no blood tests or scans that can prove a person has schizophrenia. This needs to be diagnosed by a psychiatrist who will do a full psychiatric assessment to categorize and diagnose the mental illness using one of the following manuals. Firstly, the International Classification of Disorders, ICD-10, produced by the World Health Organization in 1990, and is used as a diagnostic tool and to analyze and monitor the general health of the population. The second, the Diagnostic and Statistical Manual, Volume 5, produced by the American Psychiatry Association in 2013, and is used by health professionals to diagnose mental illness and also as a research tool. DSM-5 has been around 20, 25, 30 years. Obviously, Volume 5 is Volume 5. There's DSM-1, 2, 3, 4 prior to that. Schizophrenia is now considered to be a spectrum disorder, which is a group of related mental disorders that share some symptoms. The main disorder is schizophrenia and includes all the previous subtypes of catatonic, disorganized, paranoid, residual, and undifferentiated, which are now used as specifiers to provide further details in diagnosis, as they can change and overlap as the illness develops. DSM-5 and ICD-10 manuals give doctors guidance on which symptoms should be present and for how long in order to make a diagnosis. Two of the symptoms need to have been present for 6 months or more and active for at least 1 month before a person can be diagnosed with schizophrenia. Okay, so if you're using one of our independent learner workbooks, or your teacher has downloaded our workbook from TESS, please complete the following exercises. Briefly outline DSM-5 and ICD-10 are used by healthcare professionals to diagnose schizophrenia. Briefly outline how DSM-5 and ICD-10 are used by healthcare professionals to diagnose schizophrenia for 4 marks. Okay, you may want to pause the video at this point in order to answer this question. Okay, welcome back. So, simply, the International Classification of Disorders, ICD-10, produced by the World Health Organization in 1990, is used by healthcare professionals as a diagnostic tool and to analyze and monitor the general health of the population. There is also DSM-5, which has been produced by the American Psychiatric Association in 2013 to help professionals diagnose mental illness and as a research tool. Both DSM-5 and ICD-10 manuals give doctors guidance on which symptoms should be present and for how long in order to make a diagnosis. 2 of the symptoms need to have been present for 6 months or more and active for at least 1 month before a person can be diagnosed with schizophrenia. That may seem a lot, but you are looking for 4 marks. Okay, the next question. To diagnose schizophrenia, 2 of the symptoms outlined in DSM-5 or ICD-10 must be present and active for at least 1 month. True or false? Okay, after a little bit of thinking here, hopefully you've said false. Many of you may have said true. However, the actual criteria is 6 months and active for 1. Okay, moving on. The second learning objective, positive symptoms of schizophrenia including hallucinations and delusions. The signs and symptoms of schizophrenia vary from individual to individual, but they can be divided into positive and negative groups. Positive symptoms represent a change in behavior or thoughts which affects or distorts the sense of reality and can be intense and very distressing. Here are the main positive symptoms experienced. Hallucinations. Experience sensations that aren't caused by anything or anybody around them. Hallucinations can involve all the senses: auditory, visual, touch, taste and smell. The most common hallucination experience is hearing voices or other sounds. The voices vary in each individual. For example, they can be male or female, loud or quiet, abusive or annoying. They can give instructions and even speak in foreign languages. Hallucinations are very real to those experiencing them, even though no one else around them can hear the voices or experience the sensations. The next, delusions. An unshakable belief that he is held with complete conviction in something that is very unlikely, strange or obviously untrue. A person with schizophrenia may develop delusions as a way to explain the hallucinations they are experiencing. Paranoid delusions are common, and sufferers believe that someone or something is deliberately trying to mislead, manipulate, hurt, or in some cases even kill them. Delusions of grandeur, which is where an individual believes that they are on some imaginary power or authority, such as thinking they are on a mission from God or they are a secret agent. Disorganized thinking. A person displaying this symptom will find it hard to concentrate on anything. Thoughts will drift from one thing to another, although there will be no connection between them. Some people describe their thoughts as being misty or hazy. They will have trouble finishing reading an article or watching a TV program, and may also struggle with college work. Words may also become jumbled or confused, making it difficult for others to understand. This is known as a word salad. Okay, so another task in your workbook or on a piece of paper if you haven't got a workbook. Briefly outline the symptoms associated with hallucinations in schizophrenia. Briefly outline the symptoms associated with hallucinations in schizophrenia. Okay, you may want to pause. Okay then, so for the 2 marks here you need 2 from the following. experience sensations that aren't caused by anything or anybody around them. Hallucinations can involve all the senses: auditory, visual, touch, taste, and smell. The most common hallucination experience is hearing voices or other sounds. The voices vary in each individual case. For example, they can be male or female, loud or quiet, abusive or annoying, give instructions, and even speak in a foreign language. Hallucinations are very real to those experiencing them, even though no one else around them can hear the voices or experience the sensations. Okay, so the next question. Briefly outline the symptoms associated with delusions in schizophrenia for 2 marks. Again, you may want to pause at this point. Okay, welcome back. So, any two from the following for delusions: an unshakable belief that is held with complete conviction in something that is very unlikely, strange, or obviously untrue. A person with schizophrenia may develop delusions as a way to explain the hallucinations they are experiencing. Paranoid delusions are common, and sufferers believe that something or someone is deliberately trying to mislead, manipulate, hurt, or in some cases even kill them. Delusions of grandeur, which is where an individual believes that they have some imaginary power or authority, such as thinking they are on a mission from God or that they are a secret agent. So moving on. In the exam, you may often be presented with little scenarios. Application questions. Laura has just got her first job and seems happy, but her friends and family are concerned about her mental health, as she has recently told them that she believes the old lady who lives next door is deliberately hiding her things, following her, or wants to harm her. In addition, Laura has started to hear a voice in her head telling her that she is worthless and cannot do her job properly. Using your knowledge of schizophrenia, explain why Laura is showing the symptoms of schizophrenia. So you may want to pause the video at this point. And welcome back. So, this is an application question, and students often struggle with these. Simply, you need to pick out symptoms from Laura's case and actually interact it with knowledge from the diagnosis and classification of schizophrenia. So simply, Laura is showing positive symptoms associated with suffering from schizophrenia. Positive symptoms represent a change in behavior or thoughts which affects or distorts a person's sense of reality and can be intense and very distressing. Laura is showing signs of delusions, specifically paranoid delusions, which are common, and sufferers believe that something or someone is deliberately trying to mislead, manipulate, or hurt them, and in some cases even kill them. In this case, the old lady that lives next door to Laura. In addition, Laura is beginning to suffer from hallucinations. The most common hallucination experience is hearing voices. In Laura's case, telling her that she is worthless and cannot do her job properly. If these continue for months, then 6 months, and active for at least 1 month, Laura is likely to be diagnosed as suffering from schizophrenia. So the third learning objective, negative symptoms of schizophrenia, including speech poverty and avalation. The negative symptoms of schizophrenia can present for several years before diagnosis, and these initial negative symptoms are known as prodromal stage of schizophrenia. These symptoms often appear gradually and slowly get worse. The main negative symptoms include speech poverty, avalation, apathy, and lack of emotion. Firstly, speech poverty, social withdrawal, difficulty starting a conversation or finding it hard to speak to people, feeling uncomfortable with other people or feel they have nothing to say and will often give short one-word answers. Avalation, difficulty in planning and setting goals, no interest in socializing or hobbies. A person does not want to do anything and will sit in the house for hours or even days. Apathy, lack of motivation, neglecting household chores leading to poor grooming and hygiene, low sex drive, lack of emotion, a reduction or flattening of emotions. The range and intensity of facial expressions, tone of voice, and eye contact are reduced. Body language becomes difficult to interpret. One of the main problems with the negative symptoms of schizophrenia, as you may have noticed, is that people can find it hard to realize or understand that they are really symptoms and not just laziness. As a result, these negative symptoms can lead to relationship problems, as family or friends may think that a person just needs to pull themselves together. Negative symptoms may appear to be less dramatic than positive symptoms, but can be just as hard to live with. Okay, so you might want to complete the following tasks in your workbook and then click begin and obviously continue with the video. So the first one, outline the main differences between positive and negative symptoms of schizophrenia for 4 marks. Here, the signs and symptoms of schizophrenia vary from individual to individual, but they can be divided into positive and negative groups. Positive symptoms can represent a sudden change in behaviour or thoughts, which affects or distorts their sense of reality and can be very intense and very distressing, whereas, hence the comparison, the negative symptoms of schizophrenia can be present for several years before diagnosis, and these initial negative symptoms are known as prodromal stage of schizophrenia. These symptoms often appear gradually and slowly get worse. One of the main problems with the negative symptoms of schizophrenia is that people can find it hard to realize or understand that they are really symptoms and not just laziness. As a result, these negative symptoms can lead to relationship problems, as family or friends may think that a person just needs to pull themselves together. Negative symptoms may appear to be less dramatic than positive symptoms, but can be just as hard to live with. Okay, the next, briefly outline the symptoms associated with speech poverty in schizophrenia. If you haven't already answered this, you may want to pause the video. If not, continue. So, briefly outline the symptoms associated with speech poverty. The symptoms associated with speech poverty in schizophrenia include social withdrawal, difficulty starting a conversation or finding it hard to speak to people, feeling uncomfortable with other people, or feel that they have nothing to say and will often give short one-word answers. Okay, the next, briefly outline what is meant by the term of elation when looking at the symptoms of schizophrenia. So the answer here, elation in terms of schizophrenia is when a person has difficulty in planning and setting goals, shows no interest in socializing or engaging in hobbies, and does not want to do anything and will sit in the house for hours or even days. And the next, describe why it may be more difficult to diagnose the negative symptoms of schizophrenia. Again for 2 marks. If you've already done this, continue. If not, pause the video. One of the main problems with diagnosing someone suffering from the negative symptoms of schizophrenia is that people can find it hard to realize or understand that they are really symptoms and not just laziness. As a result, these negative symptoms can lead to relationship problems, as family or friends may think that a person just needs to pull themselves together. Negative symptoms may appear to be less dramatic than positive symptoms, but can be just as hard to live with. Okay then, moving on to the final learning objective, the reliability and validity in diagnosing and classification of schizophrenia, including reference to comorbidity, culture, gender bias and symptom overlap. As we've already mentioned, DSM-5 and ICD-10 state that for a person to be diagnosed as suffering from schizophrenia, they must have 2 or more of the symptoms outlined above present for at least 6 months, and they must have been active in the last month. However, diagnosis is rarely that simple, as there are many issues surrounding DSM-5 and ICD-10 that will question the validity and reliability of these classification manuals. We will take a look at the main issues in this section. Firstly, comorbidity. In medical terms, comorbidity refers to the presence of 1 or more disorders in addition to the primary disorder. These disorders can exist independently of each other, or they may be related. Common comorbid disorders associated with schizophrenia include physical illness or drug and substance abuse, as well as other psychiatric conditions. Here are a few examples. Physical illness, tumours, stroke, dementia, Parkinson's disease. Substance abuse, alcohol withdrawal, cannabis, amphetamines and use of steroids. Other psychiatric conditions, OCD, post-traumatic stress disorder, depression. Therefore, when diagnosing schizophrenia, when a patient presents with the symptoms of more than one disorder, Mental health professionals need to determine exactly which disorder is causing the positive or negative experiences experienced. In order to distinguish schizophrenia from other disorders, Schneider, 1974, proposed that hallucinations, hearing voices, and a feeling of being controlled by someone or something else should be considered first-rank systems, FRS, which are incorporated into the DSM and ICD manuals. According to Schneider, being able to identify FRS would make valid diagnosis of schizophrenia possible and enable doctors to make a dual diagnosis and prescribe the appropriate treatment for each disorder. However, Nordgaard, in 2008, looked at the number of studies and concluded that definitions of FRS was unclear and not operationalized, making it difficult to make a definite diagnosis. Therefore, the validity and reliability of using FRS as outlined in DSM-5 and ICD-10 is questioned. Additionally, Buckley, in 2009, argued that comorbidity in schizophrenia is poorly understood, so making dual diagnosis difficult and the prescribed treatment not always appropriate. Again, in your workbooks or on a piece of paper, complete the following exercises. Firstly, outline what is meant by the term comorbidity when looking at the diagnosis of schizophrenia, for 2 marks. Okay, welcome back. In medical terms, comorbidity refers to the presence of one or more disorders the patient is suffering from in addition to the primary disorder, schizophrenia. These disorders can exist independently of each other or may be related. Common morbid disorders associated with schizophrenia include physical illness or drug and substance abuse, as well as other psychiatric conditions. So next, what is meant by the term validity? Briefly outline why comorbidity reduces the validity of diagnosing schizophrenia. So for 3 marks here, you need to explain what validity is first. Okay, be aware of that. And then obviously how comorbidity reduces validity. Okay, so welcome back. Validity means, is the test testing what it's supposed to be testing? Therefore, in relation to diagnosing schizophrenia, are the diagnostical manuals making the correct diagnosis, i.e. diagnosing what they're supposed to be diagnosing? So, comorbidity is going to make it harder to make the correct diagnosis, thus reducing the validity of DSM-5 and ICD-10 as diagnostical manuals. So the next one, what is meant by the term reliability? Briefly outline why comorbidity reduces the reliability of diagnosing schizophrenia. Again, you have to explain what reliability is first. So, in terms of reliability, reliability is producing the same results regardless of gender, different clinicians, different countries, i.e. if someone is suffering from schizophrenia, they should be correctly diagnosed regardless of the factors mentioned here. However, due to comorbidity, the chance of making the same diagnosis is reduced, thus reducing the reliability of DSM-5 and ICD-10 as diagnostical tools. Moving on then, symptom overlap. Any problem with using the criterion DSM-5 and ICD-10 to diagnose schizophrenia is that the psychotic symptoms overlap with symptoms that are present in many other psychiatric illnesses. The diagram below highlights the problem clinicians face when diagnosing schizophrenia. Some of the actual problems include hallucinations, delusions, and they are similar to bipolar disorder. In addition, delusions are present both in schizophrenia, bipolar disorder, and OCD. So in your workbooks, explain how the diagram above demonstrates the issues of validity in diagnosing schizophrenia. The diagram shows that schizophrenia shares the symptoms, hallucinations, and delusions with bipolar disorders, therefore making it difficult to make the correct diagnosis, thus reducing the validity, i.e. failing to correctly diagnose what it's supposed to diagnose. The next question then, symptom overlap with DSM-5 and ICD-10 can lead to one clinician diagnosing schizophrenia and another diagnosing OCD. What does this tell us about their use as diagnostical tools? Simply here, they lack reliability. There are also some disorders that have very similar symptoms to schizophrenia, such as schizoaffective disorder or schizoid personality disorder, and the boundaries between these classifications within DSM and ICD are blurred, making it even harder for clinicians to diagnose the correct disorder. A study by Beck found that when a group of 153 patients were each assessed by different psychiatrists, the diagnosis agreement rate was only 54%. A more recent study by Waller looked at inter-rater reliability when diagnosing schizophrenia and found that there was only a small positive correlation of +11 between clinicians, plus 0.11 between clinicians. So the next question, discuss how symptom overlap affects the reliability and validity in the diagnosing and classification of schizophrenia, for 6 marks. So you may want to pause, or if you've already paused, then continue. So for 6 marks, there are also some disorders that are very similar to schizophrenia, such as bipolar disorder or OCD, and the boundaries between these classifications within DSM-5 and ICD-10 are blurred, making it even harder for clinicians to diagnose the correct disorder, thus reducing the validity. A study by Beck found that when a group of 153 patients were assessed by different psychiatrists, the diagnostic agreement was only 54%, therefore suggesting a lack of reliability. A more recent study by Waller looked at inter-rater reliability. When diagnosing schizophrenia, they found that there was only a small positive correlation of plus 0.11 between clinicians. Research by Sung et al. In 1981 and Cloister-Cotter in 1994 argue that such inter-rater confusion highlights the issues surrounding the validity and reliability of these diagnostical tools, because they fail to provide an operationalized and workable definition of the symptoms of schizophrenia. However, research by Farmer found that the reliability of diagnosis was improved when the interviewing technique known as PSE, present state examination, was used by clinicians. Okay, moving on. Cultural bias. As American and Western cultural ideals have shaped the construction of both DSM-5 and ICD-10, they are both emic constructs. Therefore, when they are used to classify and diagnose schizophrenia in non-Western countries, they are an imposed ethic and may not be measuring what they claim to be measuring. As DSM-5 and ICD-10 is used on a global scale, there is the assumption that there is no difference between cultures, so the characteristics are ethnocentric. Therefore, DSM-5 and ICD-10 may lack validity as a classification tool. This also shows that the characteristics lack consistency across cultures, which means they lack reliability. Therefore, cultural variations in diagnosing schizophrenia is going to be a problem, as the way a patient describes their symptoms often depends on their cultural background. For example, it is claimed that differing culture or religious beliefs or language barriers mean that African Americans and Latinos are more likely to be misdiagnosed. Key terms: emic constructs, a test that is created and tested in one country, meaning that its constructs may only reflect the norms and values of that culture. Imposed ethic, imposing the judgment and values of one culture onto another. Ethnocentric, the assumption that there is no difference between cultures and therefore culturally biased. Another limitation within DSM and ICD classification systems is that there is what may be seen as schizophrenic behavior in one culture may be seen as normal behavior in another. In some cultures and religions, hearing voices or seeing things is regarded as being healthy, is a sign of spiritual development. A study by Liu in 1995 found that many cultures seeing or being visited by a recently deceased person is not considered unusual among family members. Therefore, diagnosing someone experiencing these symptoms as having schizophrenia can be regarded as being culturally biased, so further questioning the validity of the classifications within DSM and ICD. Another study by Li reported that in Hong Kong, individuals with schizophrenia experience stigma, even from family members. Therefore, they are less likely to seek help for the symptoms they are experiencing, and doctors may be more reluctant to diagnose them as suffering from schizophrenia, which makes DSM-5 and ICD-10 of limited use in these cultures. In addition, the cultural and social background of the psychiatrist may also affect the reliability of diagnosis. For example, a psychiatrist may misinterpret a person's lack of eye contact as a sign of withdrawal or paranoia, or class their normal emotional shyness as flattening, if they are unaware that this is normal behavior within cultures other than their own. A study by Lawson in 1994 shows that such misinterpretations happen widely. They found that African American patients are more likely than white patients to be diagnosed with severe psychotic disorders in clinical settings. Okay, so in your actual workbooks, if you complete the following exercise, it is often argued that the classification with DSM-5 and ICD-10 are predominantly based on clinical and psychological research papers written mainly by middle-class Westerners and based on Western patients. Outline what effect this might have on the validity and reliability in diagnosing schizophrenia. Okay, so you may want to pause your video at this point. And welcome back. As American and Western cultures' ideals have shaped the construction of both DSM-5 and ICD-10, they are both emic constructs. Therefore, when they are used to classify and diagnose schizophrenia in non-Western cultures, they are an imposed ethic and may not be measuring what they claim to be measuring. As DSM-5 and ICD-10 is used on a global scale, there is the assumption that there is no difference between cultures, so the characteristics are ethnocentric. Therefore, DSM-5 and ICD-10 may lack validity as a classification tool. This also shows that the characteristics lack consistency across cultures, which means they lack reliability. Moving on, gender bias. There is also an argument that there is gender bias in the way men and women are diagnosed with schizophrenia. Recent studies by Alam in 2003 and McGrath in 2008 have questioned the assumption that schizophrenia is equally distributed between males and females. Is this really down to differences between sexes, or is it as a result of the diagnostical tool used, or the way they are applied? It is argued that DSM and ICD have an androcentric male bias, which leads to misperceptions about women. Even today, the medical world is dominated by male doctors, especially by those who are in specialist roles such as consultants and psychiatrists, and they're more likely to diagnose schizophrenia in men than women, even when they have similar scores on standardized measures of schizophrenia or present with identical symptoms. Hoy, in 2011, argues that this is because women find it easier to express their feelings, so clinicians are more likely to attribute their symptoms to life events or stress rather than the more serious diagnosis of schizophrenia. Hoy, in 2011, also argues that clinicians may also have observed more severe and typical symptoms in men than women, so making it easier to diagnose men as suffering from schizophrenia. Further evidence for gender or of a patient influencing diagnosis has been studied by Ellison and Hamilton in 1949, who found that men exhibit symptoms that make them appear more passive, apathetic, and socially withdrawn from society, while women become more impulsive, outgoing, and domineering, further highlighting the problems associated with the diagnostical manual. Okay then, so in your workbook, briefly outline why gender bias may affect the validity and reliability in diagnosing schizophrenia. Okay, so welcome back. It is argued that DSM and ICD have an androcentric male bias, which leads to misperceptions about women. Even today, the medical world is dominated by male doctors, especially by those in specialist roles such as consultants and psychiatrists, and they are more likely to diagnose schizophrenia in men than women, even when they have similar scores on standardized measures of schizophrenia or present with identical symptoms. Hoy in 2011 argued that this is because women find it easier to express their feelings, so clinicians are more likely to attribute their symptoms to life events or stress rather than the more serious diagnosis of schizophrenia. It is clearly demonstrated in this section that there are a number of issues that affect the validity and reliability of schizophrenia being diagnosed. As a result, it is often suggested that diagnosis could be improved if the criteria was seen as individual dimensions along which everyone varies, rather than a cut-off between normal and ill. This will be explored in more detail later in this unit. Okay, so finally, your homework task or independent task is discuss the reliability and validity in diagnosing and classification of schizophrenia, including reference to comorbidity, culture and gender bias and symptom overlap. You may want to pause here, spend half an hour to 45 minutes having a go at this, and then come back to actually listen to the rest. Okay, so welcome back. Discuss the reliability and validity in the classification and diagnosis of schizophrenia, including reference to comorbidity, culture, gender bias and symptom overlap. Marks for this are 16 marks, and you've got 6 marks of AO1 and 10 marks of AO3. Possible content, hopefully you've had a go at the essay. If not, I mean, listen to the actual content, then have a go. Very, very important you do these extended questions. Possible content, well here you need to define what is meant by validity in relation to diagnosis and classification in relation to the outline in the specification, i.e. comorbidity and symptom overlap. Define what is meant by reliability in relation to diagnosis. Again, obviously in reference to comorbidity, symptom overlap, gender bias, cultural bias. And then identification and outline of issues such as a range of symptoms across individuals, including comorbidity, symptom overlap, culture and gender. So obviously define what is meant by the term validity, relate it to obviously the issues of comorbidity, symptom overlap, culture and gender, define what is meant by reliability, and again obviously in relation to those factors. Possible discussion points, use of evidence of the reliability of major classification tools, improving the reliability, Schneider, 1974, first rank systems. Everything that we've covered in the presentation would make valid diagnosis of schizophrenia possible and enable doctors to make dual diagnosis. Use of evidence of reliability of diagnosis between different clinicians, Nordgaard's research. Range of different symptoms in different patients, positive and negative symptoms. Evidence on comorbidity, i.e. depression, mixed syndromes, schizoaffective disorders and such, i.e. Buckley's research, 2009. Factors affecting the reliability and validity, symptom overlap, Beck's research, 1961, and Waller's research, 2001. Wider implications of reliability and validity in diagnosing, i.e. the problems with labeling, cultural bias, Lee's research in 2005, i.e. cross-cultural in Hong Kong. In addition, culture and social backgrounds of the psychiatrist include that. A study by Lawson's in 1994 with African American patients more likely than white patients to be diagnosed. Issues of gender bias, Hoy's research, 2011. Okay, so just include all of that kind of research. This question is a very academic question. It's not your strengths of this, your weaknesses of that, your strengths of this, your weaknesses of that. It's about bringing in research. It's an interplay between validity, reliability. Is DSM and ICD-10 reliable? Is it valid? What are the problems, i.e. with reference to comorbidity, culture, gender and symptom overlap, and how do they affect validity and reliability? Okay, so that brings us to the end of this lesson, and hopefully I'll see you in the next lesson for biological explanations of schizophrenia.